guys, and welcome back to another session of HAS lecture series on an important aspect as far as clinical pharmacology is concerned, and that's about drug interactions. Okay, so as doctors or any other healthcare professionals, you will be always in the position where you need to prescribe more than one drug, and these drugs can come all the way from different groups having actions for different symptoms or even different diseases at a time. So it's important that you know the basics of a drug interaction so that prescription writing becomes very easy for you. You need to then just select a few drugs which do not have drug interactions or have drug interactions of a minimum level. So anyway, so let's start with this topic on drug interaction. A few topics in this session I have already covered, so I would want you to watch those videos. Anyway, when we'll come by those things, I will let you know about them. So anyway, so drug interaction is what is the pharmacological activity of a drug which is altered by a concomitant use of another drug or by presence of some other substance. Okay, we are always in a scenario, as I discussed with you earlier, is that we want to give two drugs of two different classes. Maybe they have action for the same disease, or they might be having action on different diseases, different symptoms, whatever it might be. When you give more than one drug at a time, then what you find is these two drugs can interact with each other, and that is what we call it as a drug interaction. Now the drug interactions can also occur with substances which are not supposed to be drugs, for example food, and so on. So those kind of interactions also we will be seeing across when we'll be going through this session. So that's all about it. So it's kind of a I should say learning pathway for those people who want to practice polypharmacy, that is, you want to prescribe multiple drugs at the same time, and yes, drug interactions become important. Now if you look at drug interactions, then what drug interaction can do is they can either increase or decrease the effect of a particular effect of a drug. Okay, so they can either increase it, or they can nullify the effect of a drug, or it can put the patient into, as I said, as it's written here, it can give rise to increase amounts of adverse drug reactions, that is side effects of a drug. So those kind of quantitative things, increase in the effect, decrease in the effect, increase in what I should say, kind of a side effect profile of a drug, and so on, can occur. At the same time, as I said to you, it can nullify the effect. So either the drug has an effect or not, so which depends upon the presence of the other drug. So it can be more of a qualitative I should say effect also, which can give rise which can arise if you are giving two drugs together. Especially if I'm looking at a qualitative thing, then either it should be agonist or antagonist to nullify or magnify the effect. So all kinds of things, quantitative increase or decrease, qualitative yes or no, response or no response, or kind of increase in adverse drug reactions can occur when you give two drugs with each other. Now these are all the factors which contribute to drug interaction. So as I said to you, multiple drug therapies. Okay, so it's always happens in medicine nowadays that you have drug for almost all things now. Okay, all symptoms, so you need to prescribe multiple drugs at the same time. So all these drugs have the capacity to interact with each other. So definitely that's the key in understanding drug interactions. That's the soul of the entire drug interaction as such. Multiple prescribers. Okay, so it usually happens with people who will go doctor shopping. Okay, so kind of a scenario which we always fear about. So a person can go on shopping for doctors and prescriptions, and he may not reveal what he is on. So for example, a person might be diabetic and might be taking some kind of oral hypoglycemic agent or insulin, and if he doesn't reveal it to you and you prescribe some other drug at the same time, now that becomes a problem, because you don't know that a person is already taking this drug. So either they can add to the hypoglycemic effect of a particular drug which the patient is already taking up, or it can mask the hypoglycemic increase sympathetic activity levels. So there are all the chances that patient can go into hypoglycemia and never know that he is in that kind of a stage. So all these kind of things happen if the patient don't reveal to you about the things, and you just consider that you are the only prescriber for the patient. So multiple prescribers, doctor shopping does adds to drug interactions, because people don't reveal about all what they are taking and so on at most of the times. Okay, multiple pharmacological effects of a drug. Okay, a particular drug can be a prototype drug, and it can have actions on almost all the organ systems of the body. Whether it's wanted or not, it's another thing. But a drug can have interactions with, all the organs of the body. It can affect all the organs of the body. And if you prescribe a drug which has then second drug which has specific effects on a particular organ, then it can either increase or decrease the effect on that particular organ. So a kind of a thing that you see. But of course, with tailor-made drugs, specific for disease, specific for organ, these kind of scenarios can be brought down. But then it adds on to the chances of getting a drug interaction. The fourth one is multiple diseases or any predisposing illness. So yes, if a person, nowadays we find that a person, for example, might be suffering from heart disease, he might be suffering the same time with kidney problems, at the same time liver issues, there must be a lot of edema. So you give multiple drugs for these patients, and these multiple drugs have multiple actions in the body, and even those actions get modified in disease state. So all this adds to drug interaction, right? So that's also important to know when you prescribe drugs to the individual. Okay, poor compliance of the patient. Now that's also important. Patient should be compliant with the therapy, whatever is prescribed to him. But most of the times, what you see is that patients usually are enthusiastic in the first few days of taking the therapy. Once they start getting relief, they leave on the therapy. Now, is that an issue as far as drug interaction is concerned? The answer is probably yes or no. Okay, if the patient goes and hits some other doctor at the same time, gets some other therapy, now that's fine. The patient leaves therapy, that's also becomes an issue, because the other drug the patient might be taking up, okay, might add to the problems of the patient and can exaggerate the issue. So yes, it can add, it may not add to drug interaction. But then again, this becomes an important effect or a contributing factor in cases of drug interaction. Age of an individual, I always mention age because age is like extremes. Okay, so you have very old individuals, young individuals. Now their bodies are either deteriorating in function or they are coming up, so the optimum levels have not been achieved, especially in small kids. So you will find that drugs do interact in a different way. Drug have different effects on these kind of bodies, okay, which are on the extremes. So on these individuals, I shouldn't say bodies, okay, individuals. So yes, advancing age becomes a contributing factor for drug interaction, especially the extremes of ages. And of course, at the end is drug related factors. Okay, so the kinetic profile of a drug, the dynamic profile of a drug, I should say about the structure of the drug. Okay, all this adds to drug interaction at the end of the day. Even for example, odor, smell, how it looks and so on, because the patient might just not take the drug because it's bitter pill. Okay, so even that can add to drug interaction because the patient is just not taking the drug, while he's taking some other drug, okay, at the same time. So, or he searches for some other alternative for this drug which might be having problems with the existing drug. So all these drug related factors also contribute in a way which can give rise to drug interaction. It's not always that doctors search for alternatives, it's also the patient who searches for alternative. That also has to be understood. There might be number of patients that you might be seeing or you might see in your life where they only search for the alternatives and they just start taking the drugs thinking that it's of the same group, so why not I just change and I can get a similar benefit. Now they get the similar benefit or not, I don't know, but what happens is that they can land up into drug interactions, so just because of the drug factor, right? So these all things are the ones, quite logical sequence I should say, which contribute to drug interactions in general. Okay, so now coming up to drug interactions, there are three kinds of interactions that we'll be going across or we'll be seeing in this session. The first one is the pharmaceutical interactions. The second one is the kinetic interactions, pharmacokinetic interactions, and the third one is the pharmacodynamic interactions. Okay, so we'll see one by one what these are rather than I explaining to you just right here what these mean. So these three types of interactions usually contribute to most of the parts of drug interaction. A pharmaceutical interaction, now this is something outside the body. Okay, so it has to do with the chemical structure of the drug, okay, how the drug is made and so on. So this is incompatibility in other sense. So some drugs, if you try to mix it with some other agent, it will try to precipitate, okay, it try to form hard complexes, and this is not something which is advisable because you then cannot give that drug to the individual, especially in cases of parenteral injections, because you want either a clear solution or whatever the drug exists as an IV agent, right? So a few examples of that would be ampicillin or chlorpromazine interacting with dextran in solution, so it breaks down, form turbid solutions, so the activity is lost. The other example which I remember now is about sodium nitroprusside. It's a vasodilatory drug given at times in hypertensive crisis. So if that agent exposes to light, a chemical reaction takes place and poisonous substances are formed within the substance, so you shouldn't be giving it directly on exposure to light and so on. So you should be wrapping up the entire IV set with the black paper and so on with sodium nitroprusside. So these kind of chemical interactions, I should say, which are outside the body, but you should be careful because you need to have drugs which are given in proper form. You do not want to have those turbid solutions which been given, which can prove to be fatal to the individual, can bring about adverse drug reactions or can just nullify the actions of these drugs. Okay, so you do not want either of that thing to happen. So pharmaceutical interaction is important. Anyway, we use usually known drugs, so that's not an issue that you should be remembering all pharmaceutical interactions in practice, but definitely the important ones is the ones that you need to remember because that's the way medicine runs. But if you are in a doubt, then of course you can hunt for drug information booklets, and if you're mixing drugs, especially IV infusions, better be careful. Ask your colleagues if you're a junior doctor and somebody else who can guide you on this before mixing drugs with each other. Okay, so I mean that's about pharmaceutical interactions, which is basically kind of chemical interactions outside the body of a person, but that can block the drug from being given parenterally, that is IV, intramuscular, subcutaneous, whatever it might be. Okay, so that's about pharmaceutical interaction. The second one is pharmacokinetic interaction. Now you all know what is pharmacokinetics. If you are new to my channel, go back and watch my videos on kinetics, and I already posted videos on absorption, distribution, metabolism and excretion, so go watch those videos. So I hope then you make some sense understanding pharmacokinetic interactions. So kinetics is velocity, so that velocity of a drug inside the body, or what body does to a drug in other sense, is made up of four processes. It's made up of absorption of the drug, it's also concerned with the distribution pattern of a drug, it's also concerned with metabolism of a drug, and also is concerned with excretion. So all these four components of pharmacokinetics, and you can have interactions of drug with each other, and they can either block or enhance the activity of other drugs. So that is kinetic interactions, but we need to look at a few examples of kinetic interaction. Okay, so if we look at absorption, which is the first process, of course absorption is most important as far as oral substances are concerned. And if you are giving two drugs together, oral drugs, let it be a syrup, tablet or a capsule or whatever it might be, they can either enhance or retard the absorption of other drug. Okay, so that will then definitely decide what kind of effects the drug will have on the body. So that is what you need to know about absorption interaction. So if I'm looking at a few examples of absorption interaction, then definitely I should say a few drugs, okay, like for example antacids, food, minerals, supplements containing aluminium, magnesium, so on. They can form complexes with heavy metals like penicillamine. Okay, tetracycline can form. In other terms, tetracycline is antibiotic which can form complexes with calcium in the milk if taken along with it. So they form complexes, right? So that is what is a problem, because once you form complexes, the molecule size increases. Now that molecule size is not something which the body can absorb back, and these substances then are rendered useless. So basically the formation of complexes, especially with heavy metals, with food substances, with calcium ions and so on, becomes an important factor as far as absorption inhibition of drugs is concerned. A few drugs can alter GIT pH. Okay, so GIT pH is very specific. What happens in stomach is acidic, what is down below is mostly the basic. Now we already have seen what happens with, or what is the effect of pH on the drugs, right? They give rise to either unionized molecules, that is drugs with no charge on them. Okay, if there is a like medium, for example acidic drugs in acidic medium, they like it, so no charge on them, so can be absorbed. Whereas basic drugs in basic medium, unionized, so can get absorbed. At the same time, you put acidic drugs into basic medium, they get ionized, they get charged on that, and that's why they are not absorbed. So if you are giving antacids, antacids are basic drugs, alkali drugs, and the gold standard would be aspirin. Okay, so aspirin, which is a kind of a weak acid, so it's not going to get absorbed, it will get ionized, so it's not going to get absorbed through the stomach if you are giving antacids along with aspirin. Same applies to ferrous sulfate. Okay, ferrous sulfate, in fact if I want to increase the absorption of iron, I should be giving vitamin C and so on, so that will increase absorption of iron. So it's the reverse way, you provide like medium, acid drugs, acidic medium, you increase absorption and so on. So you need to be know about how you alter the pH and how you increase or decrease the absorption of drugs. Now again, if you are new to my channel, you need to watch my videos on absorption of drug. That will give you a clear cut idea on what happens with ionization and pH and effects of that on the drug, because that is the basics of alteration of pH and how it affects and how the drug interaction takes place and so on. So that is what has an impact on absorption of drugs as far as GIT pH is concerned. The third one is about gut motility. Okay, a few drugs can either increase or few drugs can either decrease the gut motility. So drugs like metoclopramide, which are supposed to be anti-emetic drugs, increase gastric emptying time. So there is no time for the drug to remain within the GIT. It's pushed forward in a faster way. So less absorption of drugs like few drugs like levodopa, diazepam and so on. Whereas anticholinergic drug, they will put a halt on the GI motility, so drug remains inside, I should say, for a long period of time, and absorption gets affected. So a few drugs whose absorption might get affected when you are giving anticholinergic with them. So that is what you need to remember as far as drugs are concerned. Now something on alteration of GI microflora. As antibiotics, we have in the GIT, what we have is the good bacteria and the bad bacteria. So you must have heard terms like lactobacillus, which is there in a lot of yogurts, dairy products and so on. So you always tend to eat these products because these bacteria will help in good immunity, bring down chances of a person suffering from bring down chances of any other diseases of the GIT, absorption is improved, overall health is improved and so on. So, but when you give antibiotics, especially broad spectrum antibiotics like tetracycline, they can disrupt this good bacteria, and which can give rise to diarrhea, and absorption of few drugs like digoxin can get activate, I mean can get affected. So that is what you need to know when you look at GI microflora, especially with antibiotics. You should be careful when you administer other drugs because the absorption might just get affected. Now that's not going to happen in one day, that will require at least 4-5 days, because GI microflora will get damaged over a period of time. It cannot happen suddenly. Anyway, a minimal factor as far as drug interaction is concerned, but yes, that exists when you give antibiotics for a long period of time along with some other drugs. Then what you see is a problem with the absorption of other drugs. So that is about GI microflora. And the last one is malabsorption syndrome. Yes, any kind of malabsorption syndrome and problems with malabsorption, or drugs which give rise to malabsorption problems, and so there is a issue with that. So here you have a lot of vitamins which are supposed to get absorbed with digoxin and so on. So inhibition of absorption takes place, especially with mal. There are few drugs like cephalexin. I heard somewhere their absorption increases. That's also one thing I just forgot to mention. Drugs like cephalexin, which is kind of first generation antibiotic, cephalosporin antibiotic, I heard somewhere it increases, the absorption increases, especially in malabsorption. So malabsorption, a few drugs, most of the drugs I should say, absorption decreases, but a few drugs absorption increases, and that's one of the drugs. I think very rare, but you can remember that as an example as far as malabsorption of a drugs is concerned, malabsorption syndrome is concerned, and especially absorption of drugs is concerned. If that was about kinetic interactions, the second one is about distribution interaction. Now once the drug gets absorbed in the bloodstream, it gets distributed throughout the body, and there is a distribution pattern, right? So we, again, if you are new to my channel and don't know anything about drug distribution or volume of distribution, then maybe you want to watch my video on volume distribution of drugs. And about protein binding also. Okay, so there is a video posted in my 3-minute session on protein binding, and there is a full-fledged session on distribution of drug to get you knowledge about these things. So yes, distribution pattern is different for each drug. For example, what I need to tell you from this place is mostly about drug displacement. Okay, drugs get attached to proteins inside the plasma, and then they travel across. So there is kind of a protein binding. So some drugs are more protein binding as compared to the less protein binding, as compared to some other drugs which are having less protein binding. The drugs with more affinity, with more protein binding, they displace the less protein binding drugs, and once the drug is free, that is, it is not protein bound, it is active, it can give rise to effects, and if the free drug rises more than what is required, then toxic effects of these drugs can come about. So here you have drugs like phenylbutazone, which is a good, I should say, which has very high protein binding. So when it is given along with anticoagulants, it will displace anticoagulants from protein binding sites. Once anticoagulants increase, what it can give rise to chances of bleeding. Okay, same appears with sulfonamides and tolbutamide. Tolbutamide is a kind of a hypoglycemic drug. It is having sulfonamides. When given along with tolbutamide, it can displace tolbutamide, and that free tolbutamide can give rise to increased hypoglycemic effects in especially diabetic individuals. So kind of displacement reactions as far as distribution of the drugs is concerned, especially to deal with protein binding. Okay, so the third about that, about the process of kinetics, is about the metabolism process. And we have something called as enzyme induction and enzyme inhibition. So we have cytochrome P450 enzymes inside the liver, and they get induced by certain drugs. So once they get induced, what happens is that they will induce the metabolism of the drugs which come in their pathway. So they will metabolize them faster, and the drug levels will go down easily. And then you have enzyme inhibition, which is they inhibit these enzymes, and which can decrease the metabolism of a few drugs, especially which are having the same pathway through those enzymes. So there are few examples again of enzyme inducers and inhibitors. Again, there is a video on enzyme induction and inhibition by me on my channel, so you need to watch that to get a full insight on induction and inhibition. But these two things have profound implication as far as clinical pharmacology and prescribing of drugs is concerned. So here is an example about enzyme induction. The best known, the mother of all inducers, is rifampicin, anti-tuberculosis drug. When given with oral contraceptives, what happens is that rifampicin induces enzymes. Oral contraceptives get metabolized faster because they are some way related in metabolism to same cytochrome 450. And what happens is decreased plasma levels of oral contraceptives, since they are metabolized in a faster way. What happens is, with this kind of a thing, the oral contraceptives are rendered useless. So fertile lady can become pregnant if she takes oral contraceptives with rifampicin. So you need to increase the dose and need to monitor the patient if these two drugs are given together. Then we have barbiturates, which also increase metabolism of so many drugs and can decrease plasma levels of these drugs. Need to increase the dose of these drugs if you're giving with barbiturates. Now there's nothing with oral hypoglycemics, so that's wrong, sorry for that. With enzyme inhibition, yes, a few drugs will inhibit enzymes, and because of which the levels of a few drugs which follow the same pathway will be increased, because they also won't get metabolized. So if you're giving metronidazole, phenylbutazone, it can inhibit enzymes like which can inhibit enzymes which can increase the chances of getting problems with coumarins, that is anticoagulants, oral anticoagulants, and can increase their side effect profile if you're giving it along with these drugs. Again, with alcohol is metabolized in a specific way. There is a way in which it gets metabolized, but there is a drug called as disulfiram. It's an anti-addictive drug. So it can block something called as aldehyde dehydrogenase, which is the enzyme which metabolizes alcohol. So once it blocks it, levels of alcohol go up, and the person, instead of feeling the pleasure of alcohol, will now feel a lot of problems, will now have symptoms and a lot of problems associated with high levels of alcohol. So because alcohol is not going to get metabolized. So even that happens with metronidazole, cephalosporins, and so on. So that's about enzyme inhibition. But clear view on these two things have been given by me in my separate lectures. So you want to have the depth of knowledge in these two things, you need to watch my video on enzyme induction and inhibition. Now there can be interactions at excretion level also. Now excretion mostly consists of blood flow to the kidneys, and alteration in blood flow can cause a lot of problems with excretion of the drugs, and interactions can occur at this level. Alteration of urine pH, again urine pH deals with ionization of drugs and reabsorption of the drugs, so that will again have an interaction. Urine pH change will have interactions of how drugs behave in the body. So two drugs which have interactions at urine pH can behave in a different way. And we have some drugs which can competitive block active secretion of drugs, okay, across the cell membranes. So that happens even in the kidneys. So some drugs which can interact at that level can either increase or decrease the levels of other drugs. So we have these major mechanisms which are at play when we talk about excretion drug interaction. So examples of excretion interactions, the first one is changes in active tubular secretion. So there is a drug called as probenicid which actively inhibit secretion of penicillamine, and which gives rise to elevated plasma levels of these drugs. So kind of a drug interaction, of course useful on our side, because then penicillin can remain in the body for a long time and have a lot of positive impact on the body. Changes in urine pH, okay, as I said to you, if the drug is put into light medium, it won't be unionized and reabsorption is faster. As against that, you put a drug in separate medium, in a different medium, ionization, charge on the drug, so the absorption is hampered. So if you are making the urine more basic, antacids like thing, and then the chances are that the basic drugs will get absorbed, but acid drugs will be thrown out. So that is what you need to know. And of course this becomes important especially in poisoning scenarios, where you can change or alter the pH of a drug and help in excretion of a drugs outside the body. And then you have few drugs which have an impact on renal blood flow. So we have NSAIDs, that is non-steroidal anti-inflammatory drugs or painkiller drugs, which can decrease renal clearance by affecting renal blood flow. Of course that has to be taken for a long time, and which can have an impact on clearance of a few drugs like lithium and so on, drugs for bipolar disorders and so on. So I mean that's the kind of scenario as far as drug excretion interactions are concerned. Now if that was about pharmacokinetics, we also have something called as dynamic interactions. Okay, so dynamic word again points out to what drug does to the body. So we can have two kinds of dynamic reactions. We can have something called as direct pharmacodynamic interactions, or we can have something called as indirect pharmacodynamic interaction. So direct interaction would be something which is a kind of three types of interactions. One is antagonism. Okay, so we have learnt about antagonism in my last lecture. So again, if you are new to this agonist antagonist receptor phenomena, I hope you go back and watch my session on receptors and antagonist and agonist, so that this lecture becomes more meaningful to you. Anyway, so there are three consequences of direct pharmacodynamic interactions. The first one is about antagonism. So antagonism is something which you have enemy drug which is given with a particular drug, and they don't go well along with each other and they nullify the actions of each other. So kind of an antagonist effect. Summation would be something as 2 plus 2 equals to 4. So you give two drugs along with each other, and these two drugs can add to the actions of each other. So 2 plus 2 equals to 4. But there's something called as potentiation or synergism also. That is what is here. It's 2 plus 2 equal to 6, 8, 12 also. So you get more than what you expect out of positive effects of a drug, but more than the expected. So something called as synergism. So three kinds of direct pharmacodynamic interactions that are usually seen. As far as antagonism is concerned, examples would be acetylcholine, noradrenaline, have opposing effects on heart rate. Okay, so acetylcholine will put down the heart rate, noradrenaline will give rise to increase. I should say adrenaline here. Noradrenaline is basically for blood vessels and so on. So acetylcholine against adrenaline have opposing effects on heart rate. So you give them together, then maybe there won't be any increase or decrease, substantial increase or substantial decrease in heart rate, because the two drugs are antagonizing the effects of each other. Okay, then we have summation. Okay, that's what I said, 2 plus 2 equals to 4 here. So you get the benefit of two drugs given with each other, predictable effects. So CNS depressants like sedatives, that is drugs which can induce sleep, along with hypnotics. Okay, so maybe the person is put to sleep in a faster way. So kind of summative effect. And then you have synergistic effect, that is enhancement of action of one drug by the other. So here we have alcohol enhancing the analgesic activity of aspirin. Two different drugs, two different classes, two different ways of action, but still they have a good analgesic activity if you give it together. Of course we don't give these two drugs together, so no way in clinical practice at least. We don't use alcohol because we are not in a century, like 2 centuries back. It's the modern era. We don't give alcohol for pain relief anymore. So anyway, that's just a theory. Okay, so if you give these two drugs together, maybe the pain relief is much more easier. So kind of this effect with dynamic interactions of the drug. Now there is something called as indirect pharmacodynamic interactions, that is indirect. Now that was about direct, to directly hit, and what you see is that those three effects, but indirectly also it can have an interaction. Now that is if and but. Okay, so if you give this drug along with this, and what will happen, kind of a scenario. So if salicylates decrease the ability of platelets to aggregate, salicylates, aspirin for example, okay, non-steroidal anti-inflammatory drug, it decreases ability of platelets to aggregate, especially low dose aspirin. It is anti-platelet drug. Okay, if you giving along with warfarin, then what can happen is that it can induce bleeding. Okay, so it's induced, so it should be C, not S, right? So anyway, so it's sorry for that. So if you give it along with aspirin, warfarin and along with aspirin, that can have chances, the patient can have chances of bleeding and so on. Anyway, these are contraindicated anyway, so we don't give it. But if need arises, yes, you need to look at these kind of interactions in a patient. Now, if that was about dynamic interactions, kinetic interactions, and what I should say, what was that? The chemical structure interactions, that is all that we have seen till now. Now, drug interactions also means that how it interacts with some other common elements in the environment. So, smoking is a cultural issue. A lot of people smoke. So, smoking has shown to activate drug metabolism enzymes over a period of time in the liver. So, a few drugs which are mentioned here, like diazepam, theophylline, and so are metabolized more rapidly, and their effects are decreased in these individuals. So, you have smoking as a cultural factor, but if a patient is a chain smoker, smoking for a very long time, then you can find that drug induction exist in them, and drug levels will go down in a faster way as compared to normal individuals. Okay, so alcohol, so alcohol is also a cultural issue, but is consumed by a lot of people, so has an impact on how drugs interact in the body. So chronic use of alcohol beverages may increase the rate of metabolism of drugs. So I mean, it's also inducer, so it can metabolize a few drugs like warfarin, phenytoin, by probably increasing the activity of hepatic enzymes. You shouldn't be using alcohol with sedatives and other CNS depressants, especially because that can add on to the effects of alcohol. So you do not want a patient to go into depression, CNS depression, respiratory depression. So don't give alcohol along with sedatives, hypnotics, and so on. So try to avoid these drugs, because this or any other for morphine also, for example, is a respiratory depressant. Don't give it along with alcohol. No to that also. Okay, so these are a few examples on alcohol and drug interactions. Food, which is an important component, again has a major role to play as far as absorption of drugs is concerned through the GIT. We always say that antibiotics should be given at least 1 hour before or 2 hours after the meal to help in optimal absorption. Now, there are few antifungal drugs which exist which should be given with the food. So that's another scenario. But otherwise, most of the antibiotics exist which should be given on an empty stomach, because they can form complexes with the food. For example, a few of that, like dairy products, calcium content is more, so tetracycline can bind to it, from complex chelation, and absorption will be very less. Okay. Diet also influences urinary pH. Now that is minimal, but it can. Okay, so it can have an impact on what kind of drug will be reabsorbed and what kind of drug will be excreted more. Okay, of course, type of food is important as far as absorption of food drugs is concerned. Anyway, so that is also, as I said, vitamin C will enhance. So citrus fruit will enhance absorption of iron, and so on. So that's also important, but dairy products will retard absorption of tetracycline. So these are a few examples as far as food and drug interactions are concerned. I hope you like this session on drug interaction. Of course, a quick session, but we went through a lot of examples which might be of help to you to remember a complex topic like drug interactions. I hope since you are in a position where you have come up to this point, there's no harm in clicking the like button on the video. Thank you. Do subscribe, because your subscriptions do matter to me as far as my channel is concerned. Do press the like button. Do give comments on my videos, because that gives me a feedback on what is to be done next, and so on. If there's specific varieties that you want, specific lectures you want me to deliver, just let me know by my email IDs or through my channel, whatever it might be. Thank you. Stay tuned. Bye and have a good day.